Thank you. Can you hear me okay?
Yes, sounds great.
All right. And sorry if occasionally I am looking to the side. I have different screens in this office, but thank you for the introduction. It's kind of humbling. I'm a professor at UT. I've been a PT for longer than I'd like to admit. Started working in this field, back in the early 90s with animals, and then have been involved with vet school, both in small animal and in equine for a long time. So I'm here today just to kind of talk about really two biophysical agents that we are going to look at. One is shockwave, and the other is a little bit at PEMF. I am at VCSG. As you can see, we're a multi-specialty clinic in Chattanooga, Tennessee. I've worked a lot with the IAVRPT, which is a great association. I'm on the board for them. And then, of course, I'm at UT. So let's see if I can get these things to work. There we go. So this 1 hour course is going to provide a little bit of a practical review on the evidence on shockwave and PEMF. Of course, in an hour, there's only so much we can do. I do, 2 day courses on the human side in shockwave, where it's still kind of lagging a little bit. I mean, we've used it a long time in people, but we still have a lot of clinics that are not using it and don't know much about it. So again, we'll look at, the focused shockwave here, PEMF, and this is sponsored by Zoometica. I do not work for Zoometica. I do not get paid for Zoometica. I use the products and said I'd be happy to do a lecture here and there, as I do for a variety of companies, but I'm not a paid consultant. I am a VIN consultant and I'm faculty on a couple of rehab programs. But in my academic kind of primary field and research, I try not to be an industry partner beyond, helping out when I can and talking about honestly what, I think about things. So I live in Chattanooga here. It's a fancy picture. I didn't take it, but and then VCSG, we our bigger one of our bigger later things is our apheresis and transplant center. So we do have about 160 on staff, a large facility, and it's a lot of fun working with a lot of specialists. So my journey, I think in general, I'm a bit of a skeptic, and I just found the skeptical cat, which demands citations. I think he's kind of cute. But I think in the beginning, especially with Shockwave, I was like, well, what the heck is this stuff doing? And it took me a while to kind of get on board. And then after I had treated maybe, probably at least, somewhere 10 to 20 patients, I'm like, this stuff is really working. And kind of then really started to dig much more into the literature and wrote more about it. And, of course, in some of the different books we've done, we touch on it and have done some studies over the years. That's kind of my wheelhouse, is really doing, clinical trials and trying to prove the efficacy and effectiveness of rehabilitation, how we can better our patients' lives, speed up the recovery after surgery, improve function in our patients that are, non-operative, and really to provide as much literature as I can within my limited career to show that what we do helps. So what we're going to talk about is a little bit about shockwave. And the one we'll look at primarily is the PulseVet Xtrode. We'll look at a little at the evidence and some cases, and then the same thing with PEMF, the loop, the Assisi Loop and Lounge. Look a little bit at the evidence and some cases and have a Q&A. So that is our goal in an hour. While you're probably eating or trying to do something else, as we all try to do in these crazy fields, it's hard to kind of sit down. So I'll try to, as I say, be as entertaining as possible. So what the heck is shockwave? You've heard of like things like a plane breaking the sound barrier, maybe. I mean, these are very high velocity shocks, higher than the speed of sound. They can obviously have a destructive force on tissue like calcium deposits, kidney stones, things like that. Very high pressure amplitude, very short wave. And we'll look at, some of the things that these can do. And in terms of the history of shockwave, how it started back with people, and this is a picture from the Olympic Village in I believe it was maybe 96, somewhere around there when Germany brought a shockwave and they weren't allowed to keep it at the actual Olympic Village because it was, I don't know, I guess not approved in the US. But it kind of actually created a lot of interest. And in some of the older devices where people were in water and things like that for shockwave, the treatment of kidney stones, gallstones, things like that, people were noticing incidental changes in low back pain. That kind of got people interested. And then there was a big wave of research looking at how we can use shockwave for things like chronic tendinopathy and non-union healing and all kinds of things, which is, of course, today carried over to erectile dysfunction and shock and to spasticity and stroke survivors. So, we use shockwave for a lot of other things. And this was kind of a bit of its, early origin, but the Olympics did have kind of a significant impact. Germany had been a leader before that. So, but we have two major types, radial and focused. Focused is our real shockwave. It is our shockwave therapy where it's focused at a particular depth. Depending on the manufacturer, you might be able to choose 2 depths or 5 depths or 10 depths. Typically, in millimeters or centimeters, what is the target tissue? And if we know based on maybe diagnostic ultrasound or even our palpation, we can target it at that specific spot. Radial, which isn't a true shock wave, it's more of a pressure wave, but still gives good effects in a lot of cases. It doesn't allow us to choose a depth. So only focus allows us to choose a depth. The radial just kind of it's kind of like a shotgun, and that's kind of the analogy that people use is that it's going to be the strongest if I can get my mouse to work. There we go. It's going to be strongest here and then kind of spread out. The focused, we might choose to focus it here or here or here or wherever we want it to be. And there are different ways that the focus are produced: piezoelectric, electromagnetic, electrohydraulic, 3 different mechanisms for producing the shockwave. The radial, generally, we don't use as much in animals. They are louder and they can be more painful. I obviously being someone that treats both humans and animals, I do have a use for the radial in people at times, but they also understand it may be more painful and what we're trying to achieve with it. So we have the electromagnetic and the hydraulic and the piezo. These are different ways of generating the actual focused shock wave. And the one we're looking at is an electrohydraulic. So it's just the way that they create the shock wave that then passes through the gel into the tissue. So here's a picture of the one we're talking about, the pulse fed, and you can see that there's some different probes for different depths of penetration. You can see a picture of maybe a little dog, a bigger dog, a bigger dog, a horse, based on, but again, you could have a big animal, but be treating a very superficial spot. So it's really about the depth of the tissue. They do have minimal pain, minimal noise, and we don't lose a lot of the effects of the shock wave until we get to that target tissue with the focused shock wave. So there are hundreds of papers on, biologic effects. And I think, while these are nice and we use them, we really care about effect size. We care about what effect does it have on my patient. Yeah, it's nice if we can increase different growth factors or fibroblast proliferation or bone formation. But again, it's all about what happens in the end. Does the patient get better? Does the owner see the patient is better, walking better, moving better? And that's, the bottom line. So hundreds and hundreds of papers in PubMed, about the mechanotransduction and all of the things it does does on a cellular level. But for today, I'm going to focus on clinical differences. So, and what are some of the things we use it for? In people, these are kind of the things I've used it most for: lateral elbow pain, tennis elbow, those kind of things, plantar fasciitis, Achilles tendinopathies, both insertional and non-insertional, patella tendinopathies, low back pain, myofascial pain, fibromyalgia, and OA. I think in animals, our sweet spots have been, at least thus far, shoulder tendinopathies, things like biceps tendinopathies, or maybe their biceps and supraspinatus. We've got some, impingement of the tendons, medial shoulder instabilities, elbow dysplasia, basically osteoarthritis. Iliopsoas a little trickier to treat with shockwave to make sure we really get it there. Hip dysplasia, stifle OA. And then there's one paper on fibrotic myopathy I thought was interesting that used it somewhat successfully to keep service animals working or working dogs working longer. Like everything, we have some contraindications, meaning don't do it, and precautions, meaning do it with a bit of caution over open growth plates, acute inflammation, immune-mediated joint disease, infection, neoplasia, coagulopathies. I think in a lot of cases, when we don't know what something can do, we put it on this list. So, if you've got a growth plate that is still open, it's a young dog and it's actively growing, I probably wouldn't do it. But if you've had a significant fracture and the growth plate is already interrupted, you're not going to probably get any more growth, and I'm not going to worry too much about it. So these things are all kind of relative to the individual case. Safety considerations, doing it over surgical implants. For example, in people, I don't do it right over a total knee or total hip implant. I may do it in the surrounding tissue, but not right over the actual implant. Unstable fractures, avoiding the lung fields, the heart, the brain, major nerves and vessels. Again, we don't know too much. And the gravid uterus, pregnancy is listed for everything, of course. But these are, things we may still do it at certain times. We may just modify things a little bit. And so, back in the day when I started using shockwave, gosh, we really needed sedation, both in people and animals. So now the units have gotten a lot more comfortable. So generally, we don't need to clip. If there's a thick hair coat, though, we probably be better off doing it. Applying some gel, parting the hair, works in most cases. Anywhere from 500 to 1,000 pulses per treatment using this particular device. It's about a 3 to 5 minute treatment. And we might treat anywhere from just 2 times to 5 times about 2 weeks apart. That being said, I've had owners that, for example, in agility, the dog's done really well with shockwave, gotten back to, zero lameness, doing well in training, and they want me to treat once a month for a tune-up. We don't have any evidence that there's anything wrong with that, and if that's what they want to do, we don't want to refuse that either. So, we might do a lot more than that just to kind of maybe keep things at a good level. Historically, they were loud, but now we rarely even have to use earplugs unless you've got a dog that really is reactive to that. So these are some of the earlier papers, and these were good studies that showed good benefits, but they were also back in the days when we had sedation, which sedating, it's not the worst thing in the world, and then reversing it. But today's units don't need sedation. We can just go ahead and do the treatment with them, which is nice because dogs will let you know when you're over the worst spot. So, I think unless you're using ultrasound or something, or you've really palpated perfectly well in the beginning and marked it, then you could sedate and probably hit that spot. But dogs will tell you if you're on the best spot while they're awake. So these were 2 shoulder papers that were some of the earlier ones. Then we got these kind of, better trodes, and the PulseFed is one of them. There are, again, there's, most of the ones today don't need sedation, but this was kind of the original paper on this. And better patient acceptance with equal results is the bottom line. These are again some general guidelines, and again, every patient is unique. A minimum of two shockwave treatments, 2 to 3 weeks apart. We want to keep the trode perpendicular to the tissue of interest. Clip the hair and use gel. We want to use plenty of gel. Avoid the lungs or large vessels. This was some general recommendations in a vet clinics of North America paper, but again, you kind of develop your own protocols a little bit. And really, the more real estate you have to treat, the bigger the dog, the bigger the area is, the more shocks we're going to use. So, I think protocols are useful as a starting place, but we can only get so far. So here's a dog that, let's see what I've got on. I'm going to turn the volume down, bilateral elbow dysplasia that was getting shockwave. And you can see, pretty serious head bob. And it's interesting because this is bilateral, but the old verbiage, the down on sound. This is kind of tough because it's got bilateral problems. In fact, the dog actually looked a bit neuro on the right when it came in because this was a comfortable position for it to rest. The elbow was so bad. So it's a case of, and how we do shockwave to this. So we are going to go around the entire joint. I'm shooting a video with Dr. Margaret Fenist or Fenquist at something. Sorry if I get her name wrong, but she's at Cornell on kind of optimally how to do shockwave. We're looking at thinking about this joint in 3 dimensions. How do we get the joint line? If we've had images ahead of time, that helps, but we are going to focus most of the time on the medial uh, joint area where, the fragmented medial coronoid has created a lot of elbow arthritis, but we are going around the whole joint in 3 dimensions as well. So we're filming some video tutorials for Javma doing that, just helping to maybe think about best way to shockwave different joints. So yeah, you can see, an example here. Now we normally do it laying down, but we might be getting the medial aspect there. Lateral, we do hit the whole joint, but we focus on that worst spot. A couple of papers on elbow dysplasia that were force plate studies that showed significant increases, for example, in peak vertical force and vertical impulse, kind of the, area under the curve, that impulse. Peak vertical force, it's kind of the main thing we look at for drug studies as well. Does it increase the weight acceptance on that limb? And then one done at Vienna by Bob Z. Bachstaller on gait symmetry using a radial, which is a little different. We don't tend to use radial as much, but they are a lot cheaper. And some countries, they use more radial. So yeah, for example, in, the elbow dysplasia, we think about our anatomy. I'm going to think about really focusing here, but also getting around the joint in 3 dimensions and positionally. How do we, put the joint? This is an agility dog here. And let's see if it's,
Typically just from the outside of the
so you can hear it. We're starting here laterally on this dog because it really hurt a lot more medially. And we kind of got her used to it and then moved into the medial. So what are some things we might follow this with? The PEMF we'll talk about, but they may also then be able to do the PEMF or pulsed electromagnetic field therapy at home, whether with a loop or whether with something like a bed, which emits the pulsed electromagnetic field. And it's not equal everywhere in the bed. You can actually kind of see on some of their videos where the greatest areas are, but they're nice, comfortable beds with the PEMF as well. So we'll talk a little bit about that in some of the literature. I do want to say that Zoometica does have tons of videos online, and I watched some of these that are really interesting. This one by Dr. Markley on mobility and geriatrics was a great webinar, and here's one by Dr. Brunke and Dr. Bunch, and they have a lot of good things, based on, wanting to expand. Maybe you haven't used shockwave on an iliopsoas, and you can go in and kind of watch what you're doing before you do it. So I do like that they, provide this for you. So on the shoulder, we're mainly treating our tendinopathies, things like supraspinatus, infraspinatus, biceps. Typically see, minimal atrophy with them. We do our special tests. It has been used in a number of papers to treat calcifications, which is, I guess, makes sense if we're trying to break up kidney stones and things like that, that we do see resolution in a lot of these cases. But then also in our osteoarthritis cases where we're treating, chronic synovitis and we're treating the soft tissues around that joint. This is a dog of mine, crazy dog, hunting dog, that I asked the owners to get a video at home. And it's an acute biceps, and you can see just how lame this dog is at times, and at other times, kind of acting pretty normal. So, we did the exam, we did some shockwave with this dog. We did make the dog rest a bit. They were trying to get ready for hunting season. So, rest was part of it, along with shockwave, and got the dog, the goal is to get the dog back for that hunting season in a, within about a month period. So get him out for a few hunts and then really address it later on. So it was a really interesting case and a dog that was just crazy. And he's been pretty good in this video. Here's another, well, in this one, I'm just showing how we palpate the biceps tendon by externally rotating the forelimb and making sure I'm right on that tendon, palpating and positioning the limb so that I can optimally get the shock wave right where I want to get it. Because if we're not directing it to the spot where it's painful, then it's not going to do much good. We've got to get it right to the spot we need to get it. So those are some biceps cases. And again, here's another shoulder one. Let me flip the volume down on this. It's kind of a weird view, but you can see. So again, now I have the shoulder kind of externally rotated. I can get right in that spot, and another agility dog. And this dog is actually on a PEMF bed at the same time I'm doing the shockwave treatment. Plenty of gel, parting the coat, and getting it right on that spot. So in the MSIs or medial shoulder syndromes, typically, we try conservative treatment first. We might use hobbles for 4 to 6 weeks, shockwave at the insertion point, that proximal humerus medially, and at the glenoid cavity, and then the Assisi loop at home, which you can see in the picture here. And they may or may not get some PRP as well. But that's kind of our normal protocol is the hobbles, shockwave. They can do the loop then at home, and they may or may not get the PRP. But this is what we would try before surgery, unless it's totally torn. This was that interesting paper on fibrotic myopathy. They had 10 working dogs with fibrotic myopathy, and they did rehab and shockwave. If it was a full protocol, it wasn't just shockwave, of course. And I guess that brings us to that point is that if you're doing PEMF therapy or shockwave, it's part of a multimodal treatment. It's not the only thing we're doing. We wouldn't probably be very good clinicians if that's all that we did. So we're going to be doing strengthening and our pharmacologic management with it and all those other things. But in this case, it was interesting. The dogs were able to continue to work full time for 32 months from the time of diagnosis. It was a case study, I believe, of 10 dogs. It's an open access paper in Frontiers. And the combination of shockwave therapy and rehab may have allowed these dogs to continue their working capacity for a pretty extended period of time. Again, it's not a cause and effect, but certainly a condition that when we have working dogs, we want to try to extend their career as much as possible. And a loud picture here. So we have LS disease, and one of our signs is kind of that reluctance to jump and get up and do their normal searching activity. And we do use shockwave quite a bit on LS disease. We see LS disease a lot in working dogs. And these are some of the things we might see in the history. But the handlers tend to notice these things pretty quickly, everything from pain during activity to changes in their postures when, going to the bathroom. And So, we have a couple of options for these, and we can do surgery, we can do epidurals, and we do epidurals as well. In neuro, we do a series of epidurals for LS. And then for conservative management, we also do shockwave. So, we'll talk a little bit about how we do that. There are, again, papers on this. This was done at Ohio State. These were dogs that, got shockwave as their kind of major treatment using this pulse vet. They used a pretty deep probe. They, averaged the 40 millimeters with a pretty high energy in this case. The dosage is typically talked about in EFD or energy flux density, but typically you might see millijoules per millimeter squared. This one was zero point 0.3. That's a pretty high dose. It's hard to really explain what that is, but if you try it on yourself at 0.1, 0.2, and 0.3, you can, I think that's the best way to know, try it on yourself. And it's interesting. I was on Vin the other day and we were talking about modalities. Well, just in some threads on Vin, and someone was saying, I've been using a lot of modalities for a long time, and this is a, board certified specialist and rehab, and they said, there are days which I could say, you could take my laser and I'll still survive, but I don't want you to ever take my shockwave. And I thought that was kind of a striking comment, like, um, that was like, that's the one thing I really don't want to lose. And I guess a lot of people might throw an underwater treadmill in there too, but this is someone that treats a lot of chronic tendinopathies, and they were, kind of making the point that uh, the shockwave is my go-to for these. So anyway, in this study, statistically significant decrease in LS pain based on CBPI and lameness. And so this is an example of, well, I'm not looking at my volume, but we'll just let it, that's pretty loud. In this case, it's not as loud as it's going to get, but you see the dog's tolerating it well. Now that's on E4. So what does E4 mean? That's an energy level. They equate to a different energy flux density. In reality, you turn it up till generally the dog is saying, hey, there's something there, and that's a little bit uncomfortable, and then you may have to back it down a little bit, or you may be able to leave it there. It's not like you're having to cause pain and create an effect. You can get it to where they're like, hey, that's it, and leave it there, or even back it down a little bit. And I think that's pretty common in the field. Let me get that down a little bit there so we can. So, but you can see some gel kind of matted down in that area, and a similar treatment that's done in humans as well. Hey, sweetie. This was a human patient that I'm going to show just for fun because I want to.
He's 5 long. He's too right. He's too 5 left.
So I have permission to share this.
He's too 6 right. So okay, that's your 6 right.
So this is a patient of mine, or was a patient of mine. There's a navigator in Raleigh. At the time, this was, I don't know, a year and a half ago, was the sixth ranked navigator in the world. And I didn't know much about Raleigh, except that I guess it beats your back up a lot. But people bid on your services, and then you fly around the world and you help in a race, and you scout for a couple of days the track, and they have their own language of how they speak to each other. And basically you're navigating this. You can see her little notebook. Very interesting kind of thing, because the driver is just listening to what's going on, and you're kind of their eyes in a way. Anyway, they had been going to chiropractic for years and years, and had said that their back pain was rarely ever under 5 out of 10. They just kind of suck it up, but they also have to train a lot to stay in shape. And we did one treatment. After the first treatment, she said it was the lowest her back pain had been in 5 or 6 years. And it was, it's obviously not every patient's going to be like that, but I've had enough kind of like miracles with this on the human side that it's like, This is, definitely something that's changing our pathology physiologically. So this was, just one of those really interesting ones, and I just thought it'd be fun to share a human story as well, since it's a vet group, and because rally driving, it's pretty cool. You get to paid to go fly to Africa or Asia or Europe and but there's a lot of work involved in it. So PEMF beds and loops. Here we have a bed, which is a pulsed electromagnetic field, and then the loops, which can be used on various parts of the body. So it stands for pulsed electromagnetic field. It's the TEM or TPEMF is a targeted pulsed electromagnetic field. So again, being, the skeptic, I want to know what the literature is. And I've probably been using these, I don't know, I want to say 10 years, maybe longer, but they were approved back in the FDA in the 70s. And, again, it's not a cure-all for anything, but it's a pretty low-risk therapy that seems to help a lot of patients, whether animal or human, with very, few side effects. And although we do have a few like pacemakers, but and again, pacemakers is one of those things that's likely on the list because we don't know, not because it's going to make today's pacemakers do anything crazy. I can say that because my wife has a pacemaker and she's used a lot of different things. And even on a monitor, I can't sometimes get something like a TENS unit, or I can't get a TENS unit, which they say is contraindicated to affect your pacemaker at all. So, um, but we have this PEMF. Not that I'm saying you should start doing that, but I think we like to push things a little bit and test them. So some of the things it does: enhance nitric oxide, which is a big you know one of the big things that our body can use to enhance angiogenesis and vasodilation, and also signaling a lot of different cytokines, chemokines, growth factors for accelerating tissue repair. This is a recent study I saw in people that I thought was very interesting, that they were using PEMF, basically these assisted loops, during exercise, and it actually increased their ability to perform versus placebo ones. So they had real loops and placebo ones. So I guess clearly it must increase vasodilation because it allowed for a greater muscle activity. So pacemakers, again, is on the list. Hemangiosarcomas can be used safely over implants, like metal implants, things like that. Total hips, other bone plates can be used in oncology. It may help with pain relief in patients that can't take NSAIDs. You can use it over growth plates. You get a lot of treatments out of a loop, so it's only about $1.50 a treatment. And the rechargeable beds come down to about 23 cents a treatment. Whether you do this in your clinic or you buy them and resell them to patients or owners, or you just do it as part of your treatment. I'm not here to talk about making money. That's not what I do, but I'm just here to talk about how we use it. Here's just an old arthritic dog that I have a bunch of loops on. I thought this was a cute picture. And again, I'm not he's got, some lipomas, and this dog kind of shakes it standing. So this dog's got one on the elbow and one on the neck and one on the stifle. And I checked to make sure that was okay. So this dog's getting 3 loops at the same time. It had old bilateral cruciate tears that were never actually found. A lot of thickened stifles. The dog's pretty old at this point, and we're trying to just enhance quality of life. So you see the loop here and you see kind of the field. It emits a pretty big field around it. Treatment time is about 15 minutes in the acute or post-op phase. You might do it every couple of hours, just like you'd use ice. And in the chronic phase, maybe twice a day. This can actually go through bandages, unlike cold. We know that cold doesn't go through coaptation devices. We can get through bandages and casting and bedding. Some people will just tape them on post-op after IVDD. So basically in this case, we're treating most of the dog because it's going cranially and caudally. Can also, the owners can sit with the animal and have it laid on there and, encourage them to participate. They could do it prior to exercise, or maybe put them in this case, a functional standing position while they're doing it. We would remove a metal collar, but we could, again, this field's going to be big enough to treat both shoulders and the neck. Some of the papers, this was one of the NC State ones, or I guess since Natasha Alby's name is attached to it, I think of CanSort and I think of NC State, which is, of course, she's one of the leaders, and CanSort is really the big spinal cord injury group worldwide in dogs. And in this study, they had 16 dogs with surgically treated complete thoracolumbar spinal cord injuries. They were randomized to get PEMF 15 minutes for 15 minutes every 2 hours for 2 weeks, then twice daily for 4 weeks, or a placebo starting immediately after. Primary outcome was a gait score at 2 weeks, and they had secondary measures of gait and pain perception and proprioceptive function and some other biomarkers that I'm not smart enough to understand. And then they also looked at pain pressure threshold, which I've done a fair bit myself. How hard can you push before you get pain? And proprioceptive placing. And so they actually, in this case, found some positive effects of pain pressure threshold using mechanical sensory threshold. They found some improvements in proprioceptive placing and some decreases in pain. And so this was kind of one of the first big studies that said, this has some evidence in the neurologic population in dogs specifically. And again, you can do it with acupuncture too, which is a benefit. Another paper here, this was at AMC, looking at targeted PEMF on, again, hemilemonectomies. Dogs either got the real PEMF or the placebo. They looked at wound healing with a visual analog score and an evaluation wound scale was better compared with the control group. Pain medications were administered less frequently in the dogs receiving the PEMF during the 7-day postoperative period compared with the control group, with codeine administered 1.8 times more frequently in the control, and no adverse effects. These are reasonably small studies, but they do start to lend some evidence that, the PEMF can be beneficial. Some other species, with this is some LS disease in a cat, and of course, horses, it's very common in as well, and a loop on a cat here as well. So, of course, we're not limited to just dogs. We can try a lot of different things. So, what are some of my personal experiences in Shockwave in, I guess, our last 10 minutes? I've used a lot of systems over the years, both on the human side and in the vet side. And the Xtrode is, it's a really practical system. I like the fact that it has different depths. I like that it's focused. It has a broad focal zone, meaning it hits a, pretty large amount of the tissue within that zone. I'd say 90% plus of patients, probably even more, don't need sedation. Occasionally some cotton balls, but again, pretty rare. We use it multiple times every day. We have clients from hours away that come for it because, I guess they don't have one in their, in their area. And, it is a revenue source. Again, I'm not kind of the money person. I just, try to treat patients and go from there. But, I think anything that, works well and that people look to your clinic for is certainly a big positive thing. The handles, the adjustments are on the Trode here. So can kind of grab my mouse here. You can control it through here, which I know based on some other machines that some of my nurses have used, They haven't liked having to use your feet or go back and touch the machine. It's all right there to adjust the intensity. We use the lounge all day. I could probably use a few more. I mean, they're not only a comfortable bed, but why not get the PEMF at the same time? We do our rehab on them, we do our exams on it. It can be used on anything from acute pain to chronic pain, tissue healing, swelling. Clients can easily use it at home. And it does help maybe help allow for more owner involvement after the loop. After they do the loop, it's in their head. That's a good time to do range of motion or other parts of the program. And I know it can be a revenue source as well as you rent them or sell them to clients. But again, that's something Zomedica can talk to you about. So, I mean, I think in conclusion, these are two modalities that I use a lot. The shockwave and the PEMF we use every single day. I think they are pretty evidence-based. They're not going to help every patient. I would be like, crazy if I said that. I like to think of rehab, and if you've talked to me, I have my analogy of we have this picnic basket and we have maybe 10 different things in there that we could pull out for an individual patient. And our job is based on our education and experience, figuring out which are the couple to pull out for this patient. Um, and, we frequently do pull out shockwave and our PEMF. And again, it is a multimodal approach, though. We may also be doing nonsteroidal anti-inflammatories or nutraceuticals, or, a lot of exercise or range of motion or cryotherapy or other things too. So, but they are two really good tools in the picnic basket of our toolkit in helping dogs get back to activity. So I think they are, certainly worth looking at. They are modalities that pay for themselves, which is nice. It's good to be able to bill for something. We do have patients sometimes come in just for shockwave because they're getting their rehab somewhere else, and that's fine, and they don't have shockwave there. So I guess that is one of those instances where people come in just for that. And if you have questions, you're welcome to email me at BCSG, or I have a Gmail as well.